Hello, everyone. Thanks a lot again for this invitation. It's a real honor to be here with everybody. And I'm going to, hopefully in the future, we'll be in person. I'm going to give a brief overview of what we've learned about COVID-19 and IBD. So these are my disclosures. So I'm going to talk about scenarios related to COVID-19 and IBD. First, are patients with IBD at increased risk of contracting COVID-19, so actually getting the virus. Two, are IBD patients with COVID-19 at increased risk of adverse events. Three, what is the impact of IBD medications on the risk of severe COVID-19? And lastly, a bit of a current hot area, what are some of the data regarding vaccination against COVID-19 in IBD patients? So first, are IBD patients at increased risk of getting COVID-19? This is a big question early on in the pandemic that we were facing. And long story short, there's been a number of studies now that suggest that IBD patients do not appear to be at increased risk compared to the general population of actually contracting COVID-19. And these are two publications that have highlighted this. One on the left is a systematic review of studies from different catchment areas or local IBD centers comparing to non-IBD patients, the rates of COVID-19 compared between the two groups, IBD and non-IBD. And you can see that incidence of COVID-19 IBD was estimated to be around 0.3% in these areas, and the corresponding general population incidence, and this is early in the pandemic, was as high as 4%. So no obvious increased risk there. And then when you look at the national VA database, which is in the United States, the large Veterans Association hospital system for veterans of the military, it's a national system, and they matched IBD patients with non-IBD patients, and again saw that there was no increased risk of contracting COVID-19 if you had IBD. And the same group that did the initial study with the large military group, military hospital system, also looked at the risk of COVID-19 by medication exposure. So based on what medication you're taking, are you at higher or lower risk of contracting COVID-19? And what they found, looking at the two most common, two of the more common medications we use for IBD, anti-TNF medications and thiopurines, regardless if you're on these medications or not, no increased risk of getting COVID-19. So the take-home message for our patients is that you're not at any increased risk of getting COVID-19 compared to the general population, and your medications do not appear to modulate this risk either. But what if patients get COVID-19? If our IBD patients contract the infection, are they at increased risk of having an adverse event? There's been a number of studies on this now. This is one of the earlier ones and one of the larger ones where they used a large United States electronic health record database called Trinetics with over 40 million patients, and used a matching technique for propensity score matching to match on baseline characteristics that may impact disease severity or clinical outcomes, and looked at severe COVID-19 in IBD patients versus matched non-IBD patients. And what they found was that after propensity score matching, also before propensity score matching, but also after propensity score matching, the risk of having severe COVID-19, so either being hospitalized or dying related to COVID-19, was no different among IBD patients compared to non-IBD patients. So this is reassuring data. And again, I think the thing to note here is that this is across all IBD patients, considering IBD patients as a whole. So in general, all comers with IBD, if you look as a whole population, no significant increased risk of adverse events if you were to contract COVID-19. However, are there specific subgroups of our IBD patients that may be at higher risk for severe COVID-19 outcomes? We know from the general epidemiology of the disease, certain factors like age and comorbidities are major risk factors for adverse events, hospitalization, or dying from COVID-19. So to look at this, our group from Mount Sinai in New York and University of North Carolina, our colleagues there, Mike Kaplan and Erica Brenner, we teamed up to create the Secure Ibd Registry, which you may be familiar with, is an international web-based registry online. You can actually go and see the raw data and enter in cases there. And this was started soon after the start of the pandemic. And looking at data from this, which is a lot of data I'm going to show you now going forward, you can look at what risk factors among IBD patients are associated with increased poor outcomes, hospitalization, and or death. And what you can see here is that age, so on the left here, an increasing age group, and on the right, the risk of hospitalization and death, consistent with the general epidemiology of the disease, older patients do worse. So the higher your age, particularly as you get into the age 50 or higher, age 60 or higher groups, higher risk of hospitalization and death. And this holds true in multivariable analysis as well. And the vast majority of deaths in the Secure Ibd Registry, I think is important to know for all of the analyses I'm going to show you, are in patients age 60 and older. So that older age group, which consistent with the general epidemiology of the disease, are the group we need to be most concerned about. What about comorbidities? Well, in addition to IBD, so if you have comorbidities on top of your IBD, the more comorbidities, the higher risk for hospitalization or death. So you can see here 1, 2, or 3 comorbidities on top of IBD, higher risk of hospitalization or death. And really, if you have 2 comorbidities in addition to IBD, that seems to be associated independently with an increased risk of adverse events. So older patients with multiple comorbidities in addition to their IBD are patients we should be a little more concerned about with regards to COVID-19. And then lastly, disease activity. This has been something that has been associated with risk of infection and severity of infection for other infections than IBD. The more active your disease, more likely you are to have an infection or have a poor outcome due to infection. And it appears that this holds true with COVID-19 as well. This is an analysis that was presented at DDW this year, where they looked at mild or remission disease activity classification versus moderate to severe patients. And what they saw were that patients with severe or moderate disease activity were more likely to have severe disease, including hospitalization or risk of ICU, ventilator, or death. And particularly this is held in younger patients, less than age 50. And when you look at older patients, this does not appear to be as large a risk factor, likely because age is such a predominant risk for adverse events. So older patients, multiple comorbidities in addition to IBD, and patients with active disease are the patients we need to be most concerned about having poor outcomes if they were to get COVID-19. What about IBD medications? If patients are on our medications, oftentimes many immunosuppressants that we use to treat our patients effectively, are they at increased risk of adverse events? So I'm going to go through some of the major classes of drugs briefly and what we've learned over the course of the pandemic from Secure and other sources. So first is corticosteroids, so prednisone, prednisolone, et cetera, any kind of systemic corticosteroid. These have been consistently associated with an increased risk of severe COVID-19, so hospitalization, ICU, and death. And this has been in multiple analyses of Secure Ibd Registry, multivariable analyses. The risk is high as 6 to 7-fold if you're on corticosteroids compared to those not on corticosteroids for having an adverse event. And as sort of external validation of this, there's been other analyses. These are just a couple listed here, one from an Italian group and one from a United States health claims database group that showed the similar association. If you're on corticosteroids at the time of COVID infection, your risk for adverse events is higher. So to not a great surprise, corticosteroids appear to be bad actors with COVID-19, similar to other infections. What about anti-TNF biologic drugs? Reassuringly, the data has consistently suggested that there is no increased risk of severe COVID among our patients on anti-TNF. And interestingly, there's potentially some signal that it could be protective, although I take it with a grain of salt because it's observational data. So you have to be using some caution there in interpreting data. But I think the overwhelming majority of the data about anti-TNF suggests that no increased risk, maybe slightly protective. And this is seen both in the Secure cohort as well in an Italian cohort and other subsequent studies that have been done. And I think interesting external validation in the rheumatology world, where they had a large similar database to Secure, they saw similarly that anti-TNF treatment of rheumatologic disease, patients with COVID-19 who had RA, lupus, et cetera, that those patients had actually a decreased risk of hospitalization. And so very consistent across studies, anti-TNFs, patients should be maintained on them, and there's no apparent increased risk of adverse events if they were to get COVID-19. One exception to this rule may be combination therapy. So similar to other prior infections, studies from looking at other risks of infection, patients on combination therapy likely have an increased risk of developing or having worse outcomes with infection in COVID-19 as well. This was an analysis we did with Secure Ibd, where you can see patients on a combination anti-TNF and thiopurine compared to anti-TNF alone. So the comparative group is important to note. So if you have anti-TNF alone versus combination therapy, the combination therapy group is higher risk for adverse events for severe COVID-19. So again, another reason for us to look for opportunities to de-escalate our patients on combination therapy, something that we have been looking to do already pre-pandemic, and I think COVID just reinforces that. What about other biologics, anti-IL-12/23 like ustekinumab, anti-integrins, vedolizumab? Similar to anti-TNF, the signal appears to be that there is no increased risk of adverse events. Patients get COVID-19 and they're on one of these biologic monotherapies. So reassurance for patients on biologic monotherapies if they're to contract COVID-19. And lastly, what about mesalamine sulfoxallazine? This was initially a signal that we saw in the early phases of Secure IBD that there may be increased risk of adverse events among patients on mesalamine and sulfoxallazine, which is very puzzling because this has not been associated with other increased risk of infections. I don't have the data here yet, but hot off the press is going to be in Gastro soon. We had an updated analysis of 6,000 plus patients that suggests that mesalamine drugs are not associated with any adverse events for patients who have COVID-19. And I think this was probably a selection reporting bias issue early on in the pandemic that I could discuss more if there's questions about that. But the take-home message now, consistent data that mesalamine is not associated with adverse events in COVID-19. So just to finish up, what are some of the data on COVID-19 vaccines and IBD patients? Again, this is a bit of a hot area currently. So this was one of the early studies that came out of Mount Sinai from my colleague, Sinyu Wang. And what was done was in our infusion center, looking at IBD patients who are on, so this is the infusion center, all on biologics, primarily vedolizumab and anti-TNF therapies, and compared their response to vaccination, primarily mRNA, Pfizer vaccine or Moderna vaccine, compared to non-IBD healthy controls, other healthcare workers that are healthy controls. And what they found was that all 26 IBD patients, again, it's a small study, all 26 patients who received 2 doses of vaccine were positive for antibodies. And the majority of them actually achieved levels that would have qualified for convalescent plasma donation, which is no longer something we do, but it was a high threshold of positive antibodies. And you can see here that as you get out 1 to 2 weeks post-second vaccine, on the right-hand side, red being IBD patients, blue being healthy controls, there's no difference in outcomes. This is a nice study performed by Deepak Parkal at WashU and his colleagues there, called the COVA-RAPID study, which is a larger cohort of patients, over 100 patients with chronic inflammatory diseases. So not just IBD, so also RA, rheumatoid arthritis, lupus, et cetera. And I think the 2 interesting points to take home here are that patients, and these graphs show the antibody titers after vaccination. Patients on prednisone at the time of vaccination had lower antibody responses afterwards, and also patients on B-cell depletion therapy, which we don't really use for IBD, but I think is an interesting positive control, and also potentially some blunted responses in JAK inhibitor and TNF inhibitor patients, treated patients, compared to other immunosuppressants. So prednisone in particular seems to blunt the immune response to the vaccine. So if you can avoid it, not having patients on prednisone at the time of vaccination, I think is important. This is a larger study that you may be familiar with out of the UK, the Clarity study, where it's hundreds and hundreds of patients who had sampling after a vaccination. And what they found, this is primarily patients on infliximab and vedolizumab, and they found that the vast majority of patients did seroconvert after 2 doses. However, patients on infliximab and in particular combination therapy did have lower antibody titers compared to vedolizumab. And what they've seen over time in a follow-up study that is, I think, not fully published yet, they've seen that the antibody titers decline a little bit faster in patients on infliximab. So that may be a group of patients to consider for a third or early additional booster dose, for example. But overall, most patients with IBD are responding very well to the vaccine. And to correlate with this, the real-world experience, again from a large veterans hospital network in the United States, looking at over 14,000 patients across the United States, IBD patients who were vaccinated versus those not vaccinated, and they saw that there was good real-world effectiveness against clinical COVID-19 infection. So the vaccinations appear to work well for our patients. They're effective. Most patients have a good antibody response. Caveats being patients on prednisone combination therapy may have an initial blunted response, and patients on other immunosuppression, particular anti-TNF, may have a waning titer over time. So just to conclude, certain IBD patients that are at risk for adverse events from COVID-19 include those who are older, multiple comorbidities, active disease, and those on steroids. Thiopurines and combination therapy may increase the risk as well, but our biologic monotherapies appear to be low risk. Patients with IBD who develop COVID-19 should be managed on a case-by-case basis. And I think overall the data is reassuring, but this is another reason to de-escalate therapy. And you could potentially argue that if it was a very mild or asymptomatic case, that you may not have to skip any doses or stop the medication. And then lastly, encouraging our patients to get the COVID-19 vaccine, and just to be aware, though, that immunosuppressive therapies may blunt antibody response, in particular steroids. And most patients will do very well with the vaccine, and we should encourage it for all our IBD patients. So with that, I'd like to conclude and thank you for your attention, our Secure IBD Steering Committee and sponsors.